So what are kind of some of the things you're going to ask them in a subjective exam? What would be the first statement you give them?
What happened?
What happened?
Or, because it might not, nothing might have happened.
What brings you
Why are you here? Yeah. What brings you in here?
Yeah.
Something open-ended, and then let them talk until you have to steer them, because it can get out of hand sometimes. But let them talk at first and just see how it goes. And they'll tell you, I've got pain right there, a lot of times. So then I'd say, okay, well, what types of things cause your pain? What are your aggravating factors? And they'll list them. Okay, well, when I grip, it bothers me. When I lift with my palm down, it bothers me. I work in a factory, and if I'm repetitively bending my elbow, that bothers me. It can be a lot of different things. Direct pressure on it bothers it. Well, when it's bad, what makes it better? Meds, ice. If I hold my arm kind of by my side, it helps. Sometimes they've figured out stretches to do. But that gives you a good idea. I always like to ask, and I forget a lot, but if they've had any treatment for this in the past, and if so, did it work? Because that can give you a good idea. You don't want to do something that didn't work for them in the past. It probably isn't going to work again. All right. So now then you kind of say, okay, my next statement would be to try to figure out the severity, irritability, and nature. You already know, you probably have a visual analog thing done with the paperwork. So you'll know that on the pain scale of 0 to 10 where they're at. They usually draw on a body diagram, where their pain's at. So that may or may not give you some information, but you'll at least have an idea. And then you want to establish, okay, let's say you are gripping some things at work for a half hour and you stop. Does your pain go away right away? Yeah, it goes away right away. Okay, well, it's pretty much non-irritable, all right? Now, if I do a half hour, it's going to linger for the rest of the day. Well, then you're probably going to have to watch what you do with them a little bit, both on the eval and on treatment. All right? So that's, yes?
So is most of the irritability just comes from what they say, or are you taking that and then like the objective too?
Yeah, you'll look some in the objective, but irritability, though, you can usually get that in the subjective exam.
How do you know if they're just being dramatic?
They can, and it happens all the time. But if you tell them 0 to 10, 10 means you need to go to the emergency room, but they'll tell you 12, and then I'm like, really? 10, you're going to the emergency room. You have a 2 pain worse than that, so that means basically you're dying. And they laugh, and I'm like, okay, then maybe it's this. So you can kind of steer them a little bit that way, but mostly subjective, but you can kind of confirm it. With the lateral left condylosis, palpation's real big. So, you kind of know from seeing some of the past, this used to kill. Kills most people, and they didn't even hardly react. Then they're just pain hysteric, and you just kind of know that, and you put it in the back of your mind and ignore it most of the time. Okay. But that's where I would get most of it. But you definitely, I'm thinking all along, okay, I always give them the benefit of the doubt until they prove me wrong. So they have the benefit of the doubt that their pain's that bad until they prove me wrong, and I have them do things that I know should hurt, and or shouldn't hurt, and they'll have a lot of pain. Then you're like, okay. And it still doesn't mean I don't treat them any different. You treat them the same way. You try to treat them to give them what's better, but what is going to get them better, but you just don't worry about their pain as much as you would with other people if you don't think it's legit or if it's exaggerated. All right? So then what would we look at first in the elbow? So we did with this, we did what? Flexion, extension, pronation, supination. I probably would do the same thing just to see. So it's a quick screen. So I would have them go through their elbow, range of motion here, make sure they're going in. Oh, and one thing I didn't talk about is I would have them kind of fulcrum a little bit and just make sure they're going into full extension, because it's hard to tell just by looking at it. So you could either put your hand there or have them put their hand there and just see if it's comparable to the other side, or a weight underneath their arm like I showed you guys in lab, just to see how much extension they have. All right? Don't forget the screening stuff. Make sure that you're, at least bring up that you want to clear the shoulder, clear the neck, that kind of stuff to make sure. Yes.
Do you still observe scapula and everything?
Yeah.
Just like UCL?
Yeah,
Okay.
I would, because.
Is that just an always thing?
Yeah, pretty much. Because this happened for a reason, and like, let's say there's 20 people in here right now. If you put 20 to the same, say, 6-hour work day and did repetitive motions, probably 18 or 19 aren't going to have it. Maybe 1 or 2 will get some pain over there. Well, there's something that's causing that. It doesn't just, nothing changed. So there's usually something that predisposes them to that. If you can figure that out, that's a good way to keep them pain-free. Okay, you're going to do some initial stuff that we'll talk about here in a minute. So I would flex, make sure that what their extension is, pronate, supinate. Then I want to go definitely to the wrist, okay? So you want to wrist extend, see where that goes. Now that theoretically should be more of a medial epicondylosis, that's why I did it first, because you're stretching the flexor group, okay? Then I would have them flip over and go down, and then I would just do wrist flexion to stretch the extensor group, which is where the lateral epicondylosis goes, okay? Overpressure a little bit, I start out, sometimes just that, they're like, I can feel that, especially if they have their elbow straight, all right? So then I would just overpressure nice and slow, see if it increases, see if it decreases, okay, great. Then I'm probably gonna go right to palpation, okay? So then I'm gonna come up, I wanna find that epicondyle, nice and easy, I'm barely pushing. Now I'm just kind of trying to find my way where I'm at. Okay, there's the epicondyle, so I'm gonna come just off of the epicondyle, more distal, and then palpate around there, see if that's painful. If that's painful, then kind of the way I find out if they're on the extensors is I'll tell them, okay, lift your wrist up. So I think I'm on it, lift your wrist up, yep, pop my finger right off. So now I know I'm on the extensors, okay? If you get all of those, if they have grip strength issues, you can measure grip strength. I won't make you do that, but it's something you could bring up, you know, to get a baseline. And all of this stuff kind of fits, I can be pretty sure that it's an epicondylosis. It manifests itself usually with palpation pretty quick. And then you just got to figure out where you go from there. Let's say you had some proximal stability issues, you can address that pretty easy with the scapula. Maybe some modifications at works, anything they can do with their palm up or neutral rather than palm down for a lateral epicondylitis or epicondylosis helps because you don't overwork those extensors. All right, so activity modification is a big thing with elbow in the hand. As you can see from Leah.
You said with palm down or palm up?
Say that again.
You said from the palm up, palm down, what'd you say?
It's usually, if it's an extensor issue, it's palm down hurts more. And sometimes if I'm really having trouble reproducing their pain, if I do a grip strength, I'll do it a lot of times with a palm up. So you do the normal, you know, neutral one to get a baseline measurement. Then I'll turn it palm up and see if they squeeze at the same thing, if maybe it's decreased. And then if I turn it palm down and grip, sometimes holding that dynamometer as well as grip strength in this position can reproduce a little bit more, but that's only if I can't reproduce it first. Okay? So we know that it's kind of a chronic degenerative process usually. If it's just an acute incident that just happened, there might be an itis in there might be an inflammation in there. So you could tell them ice massage. I usually tell them ice massage. That's something good to do at home. You know, I tell them go 5, 6, 7 minutes, wait till it goes numb, you don't feel the cold, and then decrease it, or then go about 30 seconds or a minute more, and then stop. You can do that 3, 4, 5 times a day, whatever you want to do. I for sure would be giving them stretches here if they're tight, okay? I don't want it crazy, just a good solid pull, all right? I might do some eccentric loading, so I would have them bring it up with their hand and then just control it on the way down, okay? Especially if I thought it was more of a chronic type condition, okay? Because we know that with these chronic patellar tendinitis, quadricep tendinitis, epicondylosis issues, the studies are showing that eccentric training is working better than concentric training, and that you can work into some pain with that. Now, usually around a 4 or 5, most of the studies will show you. So, just, you know, a thought. I know we haven't gone over a ton of that stuff, but we'll hit it again pretty hard on Monday. So that's just a thought of something you can do. If you come up with something on your own, great, do it. So those would be kind of the things I would do right off the bat. What do you want to make sure of if you're on the lateral side? So we're talking about like you think it's an epicondylosis. What do you want to, part of your clearing exam would be what? Shoulder, obviously neck, but what specifically over there? What runs right over there?
Radial nerve?
Yeah, radial nerve. So you might want to do radial nerve tension test, okay? Because that radial tunnel is just a little bit distal from where the insertion on the lateral epicondyle is. All right? With a medial one, what would you want to do? With like a median left condyle, ulnar, yeah. You can always do the median. The median hits a big number of nerve roots, so the median is positive a lot of times, but on the inside, you're going to definitely want to do the ulnar because elbow flexion is completely different than the two tensioning mechanisms at the elbow with the radial nerve and the median nerve. That's both extension, okay? So you'd want to know what movements put tension on the radial nerve, what movements put tension on the ulnar nerve, and that's just basically the test, but make sure that you're knowing what components of that test rather than just getting them into a position, okay? So we, this, elbow extension is obviously one with the radial internal rotation, shoulder depression, contralateral side bending, okay? With the median nerve, it's wrist extension, elbow extension, slight external rotation, coming down to shoulder depression and contralateral side bending. With the ulnar nerve, it's just the opposite with flexion. So you just come up in flexion like that.
Is there a certain time you do that in the exam, or is it just?
Doesn't matter.
Okay.
I mean, they have to be laying down theoretically, so, but usually an elbow exam isn't as filled with things as a shoulder can be, even though you have to go up and clear the neck and the shoulder sometimes. So wherever you want. I mean, that's something sometimes I honestly forget to look at, and then right at the end I'll be like, oh, lay back down, I want to do one more thing. So that's fine. All right, so we'll do a stretch of the muscles here. May or may not, depending upon your ability, do some strengthening. You can teach them ice massage. You guys know what transverse friction massage is?
We'll learn that next week.
Okay, so you can do scraping, you can do any type of instrument-assisted soft tissue work, but I think it does work well on these, and I don't do a lot of it, to be honest with you, but the way I do transverse friction is I hold my hand like that, put it right off the bone, and I don't flip over the tendon. You want to push down, stay in the tendon, and just kind of move so you stay in it. It's going to hurt, but it usually will go numb, 4, 5, 6 minutes into it, and then you can go another minute or so, and then back off.
So you
All right.
hold that with your finger on there for 5 to 6 minutes?
Mm-hmm.
Okay.
That's why you do that, so you don't get tired. But I usually teach the patient to do it at home, so I'm only doing it once or twice a week. All right, so we didn't talk about like a frozen shoulder, and I'm gonna make you guys do the work on this one. So, what are you gonna ask them when they come in?
What brings you in?
What's that? What brings you in? Yeah. Excuse me. So, I've got this pain in my shoulder. It seems like it's been getting stiffer, over the last 2 months. I didn't think I really needed to see the doctor, but now it's starting to limit me. End ranges of motions bother it. Yeah, so that's it. So, all right, what would be the next question you want to ask? Or there's not just one answer, but what would you want to ask early in the process?
What makes it better?
What makes it better? What makes it worse? Yep, really good. Okay, what else?
Past medical history.
Yep, make sure, why would you do that?
So the thyroid issues, diabetes.
Yeah, anything that you can, anything that you can think of that, first of all, make sure that we should be treating this. So we want to make sure we rule out red flags. Also see if it can give us any information on if they're diabetic and they have a frozen shoulder, they're going to be tough, almost always, if they're severe diabetic. So yeah, you want general medical history. You'll probably have that on your form, which is nice. Usually you do a medical screening form when they first come in. So you can kind of look on that, but I'll look on that before I see the patient usually, and then if I have any specific questions, sometimes I just circle it on it so it reminds me to ask them about it. But yeah, okay, so we got what brings you in here. We've got kind of medical screening exercises to make sure red flag issues are there. Most of the time you're not going to have any. Very rarely do you have any, honestly. But you want to catch the ones that you do need. We've got aggravating and easing factors. Oh, and this was something too on some of the CPNs, 24-hour period. If you're looking 24-hour period on there, 24-hour period is just that. It's a 24-hour period. It has nothing to do with what an aggravating factor is. So The only thing that would have to do with an aggravating factor is if the aggravating factor only happens at certain times during the day. So you're more looking for like morning stiffness, you know, is it pain at night and I cannot sleep at all, depending no matter what position? You know, that's a 24-hour period thing I would mark in there, and that's usually not a good sign. It's usually not orthopedic if that's the case. Okay, so that would be a red flag thing. So when you're asking 24-hour period, the way I usually do is just say, hey, does your pain show a pattern throughout the day, or is it more activity dependent? Meaning, is it only when I do certain activities then my pain hurts? It doesn't really matter what time of day it is. That makes sense? It's just an easy way to ask it. And again, most of the time you're not going to get anything big out of it, but sometimes you do. And that can help you out. All right, so we've got what brings you in here. We've got aggravating and easing factors. We've got 24-hour period. We've got general health questions. So we're pretty good with that. You want to know what they're doing for activities, what they're doing for any sports, any working. You want to try to have an idea of what you need to get them back to. This goes with all of the subjectives, okay? That's never a bad question to ask. You can ask it the second time if you forget, it's not a big deal, but you want to know what their activity level is. I'm going to get somebody back that is 75 that doesn't really do anything versus somebody that is an overhead worker or something like that. It just, you have to maybe see them a little longer, playing a little more aggressive, those kind of things, okay? All right, so now what do we do? What are you doing in your brain right now? Not asking them. We had a form on this. Planning the, yeah. All right, so now you're kind of thinking, okay, I've got this information. What's the severity? What's the irritability? What's the nature? Is there anything that I don't want to do during this eval because of the patient is in too much pain, or the patient is, you know, you're worried that there's a tissue injury from what they're telling me, so we want to be careful. You know, anything that can give you good information on, you want to take advantage of that. That's why the subject is so important. All right? So let's say you get a severity or irritability nature. You know, the severity, it's moderate. The irritability is low. Once they have pain, it goes away quickly. The nature, it's fairly new. It's not super chronic. You know, all right, so we shouldn't be too worried about the evaluation for the shoulder. So what are we going to start with? Active range of motion. Okay, we're going to go through the active. I'm not going to go with all, and we've already done it, but let's say you're getting some limitations, okay? It's multiplanar. Their active range of motion is limited in multiple planes. Probably not going to be a contractile lesion. Not always, but probably not, because it's multiple plane, and muscles usually will have one plane dominant where they're limited in weakness. So if you start seeing global loss of range of motion, it's usually a non-contractile lesion. Okay, so a capsule, you know, I suppose it could be a fracture. You know, if it's really severe, the sin wouldn't be what we made it, so that's probably out unless it's a hidden one. But so I'm thinking, okay, we have global loss of range of motion. Well, now I want to test what?
Passive.
And see what?
How far they go.
Yeah, if it matches your active. Okay, so you want to lay them down, take away. Why do we do passive? What's the difference between passive and active?
Gravity.
Can be.
Muscle activation.
The what?
Bare muscle activation. So you're doing.
Yeah, there's no muscle activation. None. So theoretically, there's none. You got to get them to relax, and you want to let them go into, you know, you take them into whatever plane, but you're not having them actively contract it. So theoretically, unless you're stretching a contractile tissue, you're not stressing it. That's why you want to make sure they're not helping you. So you want to do the passive range of motion. So let's just say, for example, they had pain, and we don't really look at this, but let's just say pain in active external rotation, okay? Theoretically, if it was a contractile tissue, they should have pain in what direction? Passively. Pain actively? Let's say if it's, that was a bad way of wording that. Let's say it's the infraspinatus, okay? And they have pain in external rotation, which is the muscle or the direction the muscle pulls the shoulder. Where should they have pain with passively?
Internal.
Internal, the opposite motion. And then what else would be your third component? Isometric in what direction?
External.
Yeah, because that's what the muscle does. So there's your three kind of things with contractile tissues, okay? Palpation can also be one too. If you palpate over a torn muscle or a torn tendon, it's gonna be positive. So we've got our active range of motion, we've got our passive range of motion that let's just say we look at it, it's restricted globally, it's, kind of matches the active range of motion. We've got two components now. What could be a third component to incriminate that it's a passive range of motion? It's really important with adhesive capsulitis because your treatment does this. You do this a lot with treatment.
Joint bones?
Yeah, accessory motions. So I wouldn't even call them joint mobs, even though they kind of are, because your techniques for your eval are going to be very simple to your techniques that you treat with. But you should theoretically, if they're limited in external rotation, have a limited what direction of a capsular glide? Convex and concave, anterior, okay? Because in external rotation, the distal part's kind of going back, so the head of the humerus glides forward, okay? If you're going internal rotation, where should you have the limitation when you test your accessory motion?
Posterior.
Posterior. How about if you're coming flexion or scaption? Inferior, usually posterior, inferior to be honest, but I mean, you get the concept. So that's what I'm gonna wanna see like on the eval. And I might have you do, or on the practical, I might have you do one of those, things just depending upon it, all right? So now you've got pretty much confirmation. You've got active range of motion, passive range of motion, limited in the same direction, okay? It's about equal. You've got an isometric test that probably will be negative, okay? Because it's not a contractile tissue, okay? You've got a glide that should be positive in whatever direction you're going, and it should be probably non-palpably tender, all right? But they get pretty stinking sore with these things if they're aggravated. So you just want to kind of go low. All you need to see is where they're at range of motion wise, and if it reproduces pain, their pain. If it does, then you pretty solidly incriminated the capsule. Okay. All right. So what are you gonna give them? Well, let's say you want to make sure you clear the neck. Okay, it's at the shoulder. You probably need to clear the elbow a little bit. When you clear the neck, you want to make sure you're doing upper limb tension testing. You guys don't need to know why now, but it can significantly mimic a frozen shoulder sometimes. So if they have upper limb tension issues, you're probably going to want to address that. Okay? So let's say you explain to them what's going on. You explain that, okay, I'm diagnosing you with a primary frozen shoulder. It didn't really cause anything like a secondary frozen shoulder where you have an incident because of the immobilization, you got stiff, it just came on. I tell them it's usually women 4th to 6th decade, not always, usually non-dominant arm versus dominant arm, and explain to them that their capsule has kind of shrunk up on itself, so your motions are limited and painful because there's a lot of nerve endings in there, okay? And then you tell them, I'm gonna give you some stretching to do. What do you tell them? How often do you do it? How often? We'll walk through the stretching exercise, but how long do you hold it at end range? There was a term we had in the lecture.
60 minutes.
Yeah, TERT, total end range time. So you're gonna wanna know that, all right? So you usually tell them we'd like to work up to where you have the shoulder on stretch about 60 minutes, if not more. Some people will do it more, okay? And they usually get better faster when they do it.